Friends, welcome to the White Army Case Challenge series. In today's session, we'll be discussing about surgical short cases, which are usually kept for our exams, UG exams. Today, we'll discuss about swellings, and next session we'll be discussing about ulcer. In surgery, whatever the case may be, it can be either swelling or ulcer. Only two types of cases are there in surgery. Be it thyroid, be it breast, be it varicose, be it hernia, be it anything. Okay, so it can be either swelling or an ulcer. Only two types of cases. So if we are thorough with these two proformas, clinical case proformas of a swelling and a ulcer, we can manage 90% of cases in the surgery. Okay, and we can deal with any type of cases. So we shall be dealing in detail today, and we'll be covering most of the cases and also most important cases. Initially, we'll be discussing the case proforma for a swelling case, and after that, we will discuss the clinical photographs one by one. Okay, so starting with, usually these swellings will be a short case for you, and ulcer also no need of taking history and all. But if it's a long case, assuming that it's a long case, okay, we will discuss some salient features in history, and then we'll go in detail about examination. So like any other case in history, a patient complains of a swelling. So first we will be asking about the duration. What's the duration of the swelling? So in duration we will get some clue with so if it's since birth, the swelling is since birth, so it's of congenital etiology. So okay, if it's of acute or short duration, since a week, or maybe it can be either inflammatory in origin or maybe a traumatic in origin. Okay, if it's of a long duration, okay, so it can be most probably a neoplastic, or it may be benign or malignant origin. So we'll get from duration also we'll get a clue. So write examples as and when I say something. I not written in the slides, so please write down these points. Okay, 2-3 points. So from duration, if it's since birth, it can be congenital. If it is short duration, it can be inflammatory or traumatic. If it is a long duration one, so it can be most probably a neoplastic origin. So we'll get a clue. Secondly, site of the swelling. It gives a clue like what is the anatomical site from which the swelling is arising from. Then sometimes even some site-specific swellings are there. Some swellings are very specific to some sites. So we'll get from the site itself, we can make some diagnosis. We'll deal in detail later on. So for site is important. After that, the onset of how did the swelling start? Okay, it can be, there are some 3-4 types of modes of onset. It can be acute in onset. For say inflammatory swelling, okay, it can be just 3-4 days old. So acute in onset, even may traumatic. After mode of onset may be a traumatic. So after the trauma, he developed a swelling. So it can be acute in onset. It can be even insidious. Okay, like neoplastic swellings and all. It can be insidious in onset. We can't exactly say when did the swelling start appearing. Suddenly somebody noticed a big swelling. So that can be. It can be even accidentally onset. In breast swelling, like breast carcinoma and all, patient may be having for a long time, but may not have noticed. Once while taking bath, or maybe some accidentally, they might have come to know about this swelling. Or it can be even swelling may be arising from a pre-existing condition, like a keloid. Patient might have had a operation earlier, and from that scar, a keloid might have arise. Okay, so these are types of onset. We have like acute onset, maybe insidious in onset, can be accidentally noticed, or maybe arising from a pre-existing condition. For example, keloid. Next is course of the swelling, progression. Okay, how did the swelling progress? Say, for example, if it's of a swelling after the onset, if constant, the size of the swelling is constant, say, okay, it's since the beginning it's a constant, then we can think of some congenital swelling, or it can be a chronic inflammatory swelling which remains constant in size. Okay, If the swelling is regressing in size, initially it was a bigger one, now slowly it's regressing, the size of the swelling is regressing, then it can be a acute inflammatory swelling. As the inflammation subside, even the size of the swelling also subsiding or decreasing. Or it can be progressive, slowly, the size of the swelling is increasing. It can be slowly increasing in case of benign swellings, or it can be rapidly increasing in case of malignant swelling. It gives a clue. See, the patient say, sir, it was there, this swelling was there for some 10 years. It was very small, and slowly it was over the years, it's it's become very a little bigger. But since last 3-4 months, it's become very big, and since 3 months, it has grown to this size. So this itself gives us a clue. Yeah, it was a benign swelling. Now it has developed into a malignant. It's developed into malignancy. So with each of the point what we are asking, we get a lot of clues for our diagnosis. So these points are very important. After the progression, we can ask about any secondary changes. Okay, you have a swelling, right? And if there are any changes over the swelling, okay, due to like pressure maybe, or maybe any friction maybe, or if it's on the any vital structures like neurovascular bundles, or the bone maybe, he may have some secondary changes. We'll discuss in detail, so we will ask about that also. Any symptoms are there, like paralysis may be there, or some vascular deficits may be there, edema may be there. Okay, so or any movement deformity is there, movement difficulty is there. All these changes we will ask for. And then if it's associated with any other swellings, okay, this is very important. Association with any other swellings, it can be a same swelling in multiple sites, like similar swellings in the multiple sites maybe. That's one possibility. Please write down, there are 3 possibilities for multiple swellings. When you ask any swelling elsewhere in the body, there are 3 possibilities. One thing, he may have many swellings, but one is very prominent is and disabling him. So he may complain of only one swelling, but still he may having many swellings. So when we ask, are there any other swellings in the body? It can be the same similar swelling presenting in other parts of the body. One possibility. Second thing, in say in inflammatory or in neoplastic conditions, maybe lymph nodes in the elsewhere in the body. Patient may not have appreciated well, but still he may be having. That's the second possibility. Third thing, some metastatic deposits. Okay, in malignancy, there can be some metastatic deposits elsewhere. So these are the possibilities or chances for having swelling in elsewhere in the body, or having for multiple swellings in the body. Then we'll ask for some symptoms like pain or the swelling. Whether the swelling is painful or not. Pain may be due to the pressure exerted by the swelling over the skin, or it can be it may be arising from some nervous tissue, or it can be some inflammatory pathology will be there that can be causing pain. So these are the causes for pain or swelling, or even the fever. Again, fever may be because of again inflammation, or it can be even in the malignancy. Example, in which malignancy swelling may be associated with fever? Anyone say? Commonly, very prolonged fever with multiple. Very good. So lymphoma. Okay, lymphoma can be associated with the multiple swellings as well as, and very good. And then we can ask for other symptoms like loss of appetite and loss of weight, and mainly to rule out Pall-Epstein fever. Very good, Vishrut. And loss of appetite and weight, mainly to rule out this tuberculosis and malignancy, and other malignant features, specific malignant features we can ask for. And if you high suspicion is there, is that it's a malignant origin, you can even ask about the features of metastasis. Okay, and yeah, one thing we always stress upon, that is tuberculosis. In India, like in all our developing countries, this tuberculosis is very, very common, and it's said that every 1 in 3 is affected with tubercular bacilli. And this is the one disease which can manifest like anything and everything. Its complications are vivid, and it can be present like anything. So you should always rule out tuberculosis in every case. So the history of tuberculosis is very, very important. Okay, So we know what are the swellings caused by tuberculosis. Okay, we'll discuss. So we have to ask about the history of tuberculosis and previous surgery. Okay, previous surgery is very important. Maybe a recurrence or maybe some like we said, it may be keloid and other things. So previous surgery history is important, or any chronic illness like diabetes and hypertension. It can be causing some complication. So that's also important. And in the past history again mainly for the recurrence thing, and personal history. In personal history, addictions, we know this alcohol and nicotine are known to cause many malignancies, so that history is important. Family history is very very important, and many things run in families, like example, any swellings which run in families. Common benign swellings you can name. Malignancy, all, like breast cancer, thyroid cancer, men, everything. Yeah, neurofibromatosis. Very good. What's that called? The syndrome is called von Recklinghausen's disease of nerve. You should you should specify von Recklinghausen's disease of nerve, because there's another von Recklinghausen's disease of bone also, which is caused by hyperparathyroidism, I think. Okay, so you have to be specific. So that's why this history is important. And treatment history for this swelling, whether he has taken any treatment beforehand, before coming to you, that's pertinent. You can ask that. So this is mainly the history part, but most of the swellings are like clinical in diagnosis, and with minimal in examination also we can diagnose. So history, these are the salient features. Let us not miss these points. This will definitely give us a lot of clues in diagnosing. Next, examination. First, as usual, we do the general survey. Why do you think we should do? There's a small swelling. Okay, there's a small swelling in the say in the thigh. Okay, what's the necessity to do general survey? Can anyone say? Very fluctuant one. Since 1 week, a patient is having a fluctuant swelling in the very painful swelling in the thigh. We should look for enter to general survey. Any idea? No, not fitness. Fitness, okay. Okay, fine. Yeah, you're all right. Yeah. Mainly, what I meant was there's a big abscess in the thigh. Okay, patient may be toxic. If you just look at the abscess and drain, it will not be enough, right? So patient may be having other features of septicemia or toxicity. So in each and every case, it's our duty to approach the patient in a holistic manner. Okay, not just the swelling. Each and every patient must be approached in a holistic manner from head to toe. So we will do the head to toe examination. Okay, in each and every patient of that systemic examination. In that you are right. Okay, to look for any say tuberculosis, maybe that gives a clues. When we do systemic examination, pulmonary respiratory examination and all, we'll get a clue that what may be the underlying cause for this swelling. So if we do this general survey and systemic examination, we will be well equipped with a lot of information to going before before doing the local examination. Okay, so local examination, as we always do: inspection, palpation, percussion, and auscultation. Not much important here, but we'll do discuss long case only. Okay, in inspection, some of the important points which we should not miss at all. Like, I have made it simpler for you, okay, to remember. Like you can remember as site, size, shape, the surface of the swelling, over the swelling, skin over the swelling, surrounding area of the swelling, and some other points we'll discuss. Okay, so first thing is site. Why site is important, I told you. Okay, and one disclaimer is there. Almost all the pictures used in our presentation is all my own cases which are treated. Okay, so I have taken permission. I always take the photographs before I operate. So I have taken the permission from my patients, so I can use it without masking them. So disclaimer we have. So some site specific swelling we told. Okay, so here see, this is a typical site of the. Can anyone diagnose this? Okay, you're all right. Dermoid. So yeah, this swelling was there since. I'll give you a clue. This swelling was there since birth. Okay. So any particular, it's a specific dermoid. There is a name for this. External angular dermoid. External angular. See at the outer canthus of the eye. There is an external angular dermoid. Okay. This is the one. And okay, this we will discuss in detail a little bit more. So it can be even the internal angle of dermoid. It can happen, or it can occur at the pre-auricular and post-auricular region. Anywhere there is a fusion of embryonic structures. These are all called sequestration dermoid or inclusion dermoid. Some amount of the epithelium is drawn inside the dermis, and from there, due to foreign body reaction, these dermoids appear at the sites of which bony structures join. Can you? This is next question. In case of dermoid, this is one of the common case kept for you. One question asked: which are all the processes joined here to form this and to cause sequestration here? Anyone? FNP and maxillary process. Okay, FNP and frontonasal process and the maxillary processes joined here. And similarly, the internal angular dermoid and other things. We'll discuss many more examples, okay, subsequently. And yeah, what is this? Anyone? See, again, very specific. This most of us will be having this. Our friends will be having. They'll come to you. See, what is this? Maybe some tumor. Maybe I'm really afraid. What to do? Okay, so we'll just reassure them. Nothing to worry, my dear. This is just a ganglion arising from the tendon sheath. Just a fluid is collected there. Need not do anything. If it's just symptomatic, affecting your movement or anything, then we can do like just aspiration, we can do marsupialization, we can do, if possible, excision of the ganglion can be done. Okay, many are possible, like chances are there. So we should know these are all the common day-to-day cases we come across. We should know all these. So this is very site specific, nearly most common near the wrist. Okay, ganglion. What is this? What is this? We just discussed this. Yeah, again, dermoid. Very good, Aditya. This is post-auricular dermoid. Okay, post-auricular dermoid. What is this? Since birth. Teratoma will be little more, more still downwards. Okay, it is a simple meningocele. Okay, please don't say myelomeningocele and all those things. Okay, because we can't really make out. If it's only burst open, then we can see the spinal cords and all. Here only it is meninges seen. So we'll just say meningocele. Okay, not meningomyelocele and other things, unless it is ruptured. So it's a type of spina bifida, we know. So it's a spotter. Again, it can occur anywhere in the midline, from the occiput to the near the sacrum, anywhere where the spinal canal is there, where the what is this meninges runs. There we can have this meningocele. So this is again a site specific and spotter. Okay, next coming to these are some site specific examples. Coming to the size of the swelling. Why important to know for the look for the again progression size. Earlier it was 2 centimeter. Now it is like progressing. Now it's 5 centimeter. That means it's slowly progressing. Earlier it was 3 centimeter. Now it is 1 centimeter. That means it is slowly regressing. So for to know the treatment like what we are treating, whether it's okay or not, or for follow-up things, everything is important. Size of the swelling is important. So ideally it should be measured with vernier calipers, but it's not usually commonly available in our setup. So we can use a scale in centimeters. Okay, this about the size of the swelling. Yeah, we have, please, my dear friends, we have told this many a times. This all, don't use this all age-old customs like as big as a peanut, as big as a musambi or watermelon. No, all these terminologies are no more used. Okay, it's very strictly, please avoid these terms, because there is no standard size for a lemon or peanut or whatever. Okay, lemon is available as big as even a watermelon also nowadays, or some lemons are like, we know. So please just restrain from using such terminologies. Just ask the patient how big it was initially. Patient will, with a hand sign, he will show something. Okay, like what is the size. So approximate that. Okay, with centimeters, approximately you take a measurement and say, earlier initially approximately it was 2 into 2 centimeter. Sir, now it has progressed to, now you can see, appreciate what's the real size now. So now it's approximately it is 16 to 6 centimeters. So both length and breadth. Okay. So that's about the size. Next, the shape. Yeah, most of the time, even the shape of the swelling also gives us a clue. Okay, it can be like see here, it can be spherical in shape, or it can be globular in shape, or it can be ovoid in shape. Okay, it can be what's it? It can be regular shaped or anything. Okay, but don't say that again in thyroid again butterfly shaped and all. Okay, if both the lobes, even including isthmus, is like enlarged, only then the typical it looks like a butterfly shaped, but not all the swellings. Okay, a butterfly shaped swelling moves up and down. No, please. Okay, don't try to exaggerate things. However you look like. Okay, however it looks like for you, you can just mention that way. Okay, and again, you know what terminologies, when to use 2D dimensions, how to use spherical, you say in the 3 dimension we say globular, all those things we should know. Not a mistake, but for a better presentation I meant. Okay, some examiners are, if they want to catch hold of you or if they want to irritate you, they can they can find some small mistakes like this. So let us be as perfect as possible in our presentation. From our side, let us err minimally. Let them ask or let them take like irritate us as whatever they want, but from our side, let there be minimal mistakes as possible or minimal errors as possible. So let us try to be improved day by day and perfect ourselves. That's about shape of the swelling. Then coming to the surface. So we discussed about the site, size, shape, and fourthly, the surface of the swelling. Surface on inspection, it can be, it can have a smooth surface, it can be nodular, okay, multiple nodules, or it can be very prominent, bosselated, or a very lobular type, okay, or it can be very irregular, uneven type of surface can be there. These are the possible types of surfaces. See one example for you. How does it look like? What do you think the surface of the swelling here? Yeah, it's smooth surface. Very good, wonderful. Okay, can anyone tell the diagnosis here? Yeah, it can be. If you look carefully, it can be lipoma is okay. Yeah, Aditya, right. Sebaceous cyst it is. No, cystic hygroma. Come on, Rakesh. Where is it? Oh, it's somewhere in the back. Can it a cystic hygroma can occur there? It's a sebaceous, small punctum is there. If it's clearly visible, small black dot. Can you see here? Okay. Uh, okay. So it can be like, you can say a lipoma, but on inspection, okay, punctum is seen. So next, see what is this? Thyroid swelling. Okay, so it is, see, it can be, you say multinodular, but it can be nodular surface, you can say, or even you say bosselated surface also. Okay, nodular surface, for example. See what is this again? Very bossel. This is, what is this now? Tell me. Very commonly kept case for you. It's a must. Yeah, this is lipoma. Okay, it's a lipoma. It can be so big. It can be even intramuscular lipoma arising from the muscle, maybe, or okay, such big lipoma it was. It can be, see, bosselated surface. You can see in usually lipoma you say lobulated surface. In thyroid we say nodular surface, and even for lymph nodes matted we say matted. Okay, that's about surface. Yeah, what is this? See, what is this? What is this? Again, typical spotter. This will be kept for exam, not keloid. Yeah, it's a parotid swelling. Yeah. Again, I want to make one thing sure here itself. Yeah, just your diagnosis should be, sir, it's a parotid tumor. Okay. Then what may be the possibility? Then they ask, then sir, it can be pleomorphic adenoma. Okay, because it's the most common one. Because see, why I'm telling all these, we usually tend to still directly the pathological diagnosis. We don't know. Okay, pathological after biopsy only we can confirm. So as far as possible, try to say the anatomical, etiological, and these conditions. Okay, these diagnosis we know what, but still try to be more humble and submissive and say, so it's a parotid. It's originating most probably. It looks like originating from the parotid. So it's a parotid tumor. Most probably it's a pleomorphic adenoma because most common one. So that way we should be, okay. Don't directly say it's sarcolemophic adenoma or it's we say it's follicular carcinoma. We don't know. Okay, it can be anything. It can be, okay. Only after biopsy we can confirm. So this is the one most commonly done mistake, directly telling the pathological diagnosis. Please let's try to avoid that unless the examiner themselves ask for it. Okay. Then coming to the fifth point, that's the skin overlying the swelling. Over the what will we look for? The color. Okay, like color gives a lot of clue. Like if there is a redness or the erythema is there, it may be of inflammatory origin, or some pigmentation is there. Okay, yeah, very good, Arjun. Ranula looks bluish, or red, dark red in case of like hemangiomas, capillary hemangiomas, purple in case of venous hemangiomas, bluish in ranula, blackish in some moles or nevi. Okay, like that. Some color itself can give us melanoma. Very good. Color itself can give us a lot of clue. Pigmentation, chronic like irritation or chronic inflammation can be caused pigmentation or that swelling. So scar, any previous operation scar will be there. So that should be looked for to understand about the recurrence and any secondary changes over the swelling like ulceration, fungation, other things. Okay, any pressure necrosis is there. Okay, any other thing other things over the swelling. And then over the skin, we'll also look for any dilated veins, any prominent veins, okay, because of the venous congestion or pressure over the veins, there can be dilated prominent veins can be there that we should look for. See, what is this now? Tell me, what is this? See, just with the color only, we can tell. It's inflammatory in origin, and some pointing. See, one white pointing is there. Okay, the pus pointing. This is nothing but abscess. Okay, submandibular abscess. Okay, it's very clear. See, even just one point can help us in diagnosis. How nice, no? How good we feel, no? Just with one point, we can directly do the diagnosis. Okay, so that's how. When we are clinically, our clinical acumen is good. When you are clinically thorough, it's so helpful. Okay, what is this? What is this? Very good, very good. Who's that? Very good, Arjun, Rishabh. Very good. Well, yeah, it's keloid. See, can we make out the scar here? This is a scar previously operated. From there, this thing is okay, arising. Swelling is arising. So this is a keloid. So what is this now? What is this? See, one just like one punctum can help us in diagnosis. Okay, so this is a sebaceous cyst. We'll discuss about the detail about the sebaceous cyst, lipoma, and dermoid at the end. Okay, these are three are more very important. We'll discuss. And surrounding area, like look for any changes like pigmentation, any discoloration, any edema is there, any wasting of muscles, anything is there. We have to look for. You know what's the classification? Yeah. We could have discussed another way using the classification of the swellings. Okay, benign swellings like all the swellings are classified. Maybe depending on the etiology, it can be either congenital, okay, or inflammatory, or neoplastic. Neoplastic and benign or malignant. Then it can be traumatic, like hematoma and bony, like fracture, displaced fracture. All those things can cause a swelling, and others like warts and sebaceous cyst, okay, epitheliomas. So how do you remember is just remember with mnemonic what I made. CINTO, CINTO. Okay, CINTO, congenital, inflammatory, neoplastic, traumatic, and others. Okay, this is the simple. So for each point, like for duration or onset, whatever I told, with this in background in mind. Okay, CINTO for congenital, that this will have a since onset will be since birth, duration will be of long duration, or progression it will like that. Can each point you can correlate and tell with the, if you know the classification. Congenitally, give me some example for congenital swellings. Some example for congenital swellings. Yeah, cystic hygroma, dermoid, omphalocele, hemangioma. Perfect. Perfect. Congenital hydrocele. Okay. Baker cyst. Okay. Milroy's disease, thyroglossal cyst. Perfect. Okay. Perfect. And what about the inflammatory swellings? Example for inflammatory swelling, abscess. Very good. First thing should be abscess. It can boil. Carbuncle. Have you know? Do you know carbuncle? What is a carbuncle? Where do you get lymphadenitis? Very good. Carbuncle. Where do you get carbuncle? Associated with diabetes. Very good. That's cold abscess is associated with TB. Yeah, you will be. I really wonder you guys because about you. Before I could even utter my question, the answer will be like ready. I really don't understand whether you keep all the answers written beforehand and keep just to press enter so that the answer will be great, really great. See, you people have to motivate us to do better in better life. Okay, thank you. And next is coming to neoplastic. Neoplastic can be what is this? Leah is telling is pigmentation, discoloration, do different entities. No, dear. Both are similar. Okay, it can be pigmentation can be either hyperpigmented or hypopigmented. Hypopigmented is nothing but discoloration. Okay, both are you can use both the words you can use. So neoplastic, we were telling about neoplastic origin. It can be benign or malignant. Okay, benign examples. Example for benign, all the cases kept for you, all be benign only. Lipoma, okay, multinodular goiter. Again, adenoma. See, don't use this adenoma and all. It's all pathological, right? Okay, fibroma, neurofibroma. Very good. Edema over swelling, not. It's edema around the swelling. Okay, the swelling will be there because of the venous compression. If the swelling is sitting on the vein, it can cause venous congestion and cause little bit of edema. Okay, around the swelling, but swelling will be separately visible. That's all. Okay, BCC. That's all. Yeah, for malignancy. Look for. Yeah. Okay. So many examples. Then others like others. I told you already. Sebaceous cyst, or maybe warts. Papillomas, epitheliomas, and other things. Okay, good. Not next surrounding. Yeah, we discussed about the surrounding. Then coming to the others. Yeah, others are some important things are there. Number of swellings very important. Patient may not have appreciated. He may be having swelling in the back, so he may not appreciate it. So it's our duty to look for it. So number is important. Single or multiple. Give me some example where there is a multiple swellings. Okay. Yeah. See, already ready. Arjun is always ready. Neurofibromatosis, very multiple neurofibromatosis. Okay, that's one recklingosis. We already okay. Multiple lipomatosis. What is that condition called? Multiple lipomatosis. What is that condition called? Derkham's disease. Very good, wonderful. Then what is multiple sebaceous cyst? What is that condition called? Multiple sebaceous cyst. One syndrome is there. Multiple sebaceous cyst. What is there? Yeah, Gardner syndrome. Yeah, wonderful. Shantala, Gardner syndrome. Then one more someone told already. Diaphyseal achalasia. Okay, and yeah, all this can present with multiple swelling in the body. Okay, so that gives a clue. We should look for that. Then color. Color already we discussed. What's the importance of color? And margins. What do you mean by margin? You can say either margin. Margin is usually used in ulcers. Here we use, in my time, we used to say border. Okay, border we used to say. Now they interchangeably it can be used. What is margin? What do you mean by margin? This is a boundary between the normal and the abnormal. Okay, very good. Between the normal and the abnormal, there's the boundary is called margin. Okay, so can we make out the entire margin of the swelling around the swelling? That's important. Okay, entire margin, complete margin can we make out? So margins can be, please write down. These are very important. We usually tend to confuse these things. Margin can be two types, either well-defined or ill-defined. See, listen carefully. Margin can be whether well-defined or ill-defined. Well-defined means we can clearly see the entire complete margin of the swelling. whole circle, not circle, but whole complete margin we can see. That is well defined. If you cannot make out half of the swelling, maybe underneath something like in MNG and all, it can be sorry, thyroid swelling, it can be underneath the sternocleidomastoid maybe, or maybe some abdominal swelling can be underneath the some structure. So we can't really make out the entire swelling. Okay, what's the, so that time we say ill-defined swelling. Okay, clear, well defined and ill defined, clear. And again, well defined, then is sub classification. Well defined can be either regular or irregular. Now there is no, don't confuse with irregular and ill defined. Okay, the entire margin can be made out and it has got a particular pattern. Okay, any uniform pattern it has got, then we say it's regular. It's very irregular, some, there is no specified pattern or any some, we can't really say which shape or anything like that, any uniform pattern is not found, then we say well defined but irregular. Is it clear? Clear? No doubt? Should I repeat? So a margin can be well defined or Pavan, margin can be well defined or ill defined. Okay, well defined or ill defined. Well defined can be, if we can make out the entire margin completely around the swelling, it is well defined. If we cannot make out the entire, only half of the swelling can be well seen, then it's a ill defined. So well defined can be either regular or irregular. Okay, okay, that's margin. Then extent is important. So from any bony prominence or any bony like a landmark, we measure. Okay, we measure the swelling margins and we say this is extending from here to here. Okay, so just to make the examiner clear where exactly it's situated, this extent is important. And after that, yeah, visible cuff impulse. Okay, if you think the swelling appears any cystic or soft, only then you can do, not for all the hard swellings and all, you don't do visible cuff impulse and things. So any soft or if you think it's arising from any cavities, like any cavity, maybe abdominal cavity, thoracic cavity, spinal cavity, cranial cavity, any cavity. Okay, so then you can do this visible cough impulse. What do you mean by cough impulse, my dear? What do you mean by cough impulse? Tell me. Define. Someone say, ask you, what is cough impulse? What do you say? When you say cough impulse is present. Okay, pulsation effect, swelling on coughing. Yeah, correct. Prominence. Yeah, that's the word. Prominence, who is SD. So there is an increase in the size of the swelling, synchronous with coughing. Okay, is it clear? Then they ask you what are the types of cough impulse, you know, all those things, expansile cough impulse and thrill like, and many things are there. So where all you get, tell me, where all you get cough impulse positive, like, give me some example. Hernia, very good. Yeah, Morris's cough impulse in case of saphenavarex or varicose veins. Helm, yeah, Prajwal K attended our class, I think. He's telling my Helm, okay, mnemonic is Helm. H is hernia. E for, what is Prajwal? E for encephalocele, depending from the cranial cavity, if it's arising, okay, or even the spinal cavity, okay, meningocele and all. So E for encephalocele, L for laryngocele, from the laryngeal cavity, E for from the thoracic or pleural cavity. What is that? Empyema necessitans. Okay, from pleural cavity it ruptures and comes to the subcutaneous, this thing. There's communication. So it's called empyema necessitans. And M for again meningocele. Okay, these are the things: encephalocele, meningocele, laryngocele, and hernia and empyema. These are the which gives prominently the cough impulse. Okay, clear? Next, any visible pulsation, any arterial or venous pulsation seen. Okay, we should look for tangentially. We should sit tangentially for the to the swelling and look any small pulsations are seen or not. So there are again two types of will palpation. We will discuss in detail about the pulsation. Then coming to the movement. Okay, movement of the swelling. Whether movement swelling is moving with anything. It says important in case of abdominal swellings. Okay, and if there's a swelling is in the neck, we can ask for patient for some specific test like moving with the deglutition, movement with like protrusion of tongue and all. Give me some examples where the swelling moves with deglutition. Examples. Okay, any thyroid swelling? Perfect. Thyroglossal cyst, very good. Subhyoid bursa, very good. Delphian nodes, what are those case? What is the Delphian lymph node? You're right. What are those Delphian lymph nodes? Pretracheal, very good. Pre or paratracheal lymph nodes will move. Then even some extrinsic carcinoma of larynx, okay, that can also move with deglutition, okay. And we know which moves with protrusion of tongue is thyroglossal cyst and the fistula, okay. Why and all, there's inevitable questions and invariably asked. We should know that. And after that, joints, we should look for adjacent joints, movement, deformity is there. These are the things in inspection. So let's revise once inspectory points. So site, size, shape, surface, and surrounding, 5 S's. And after that, we should look for the number, the color of the swelling, margins, extent, visible cough impulse, any visible pulsations are there, and moving with respiration or deglutition, protrusion, other things. And please, again, what I want to stress here is this proforma is in general, dear friends. This proforma is in general for all the swellings. It's our what we should make that discretion. It's our discretion where to apply what. Okay, it cannot be taught like individually. This proforma for lipoma, this proforma for no. This comes with discretion, our own discretion. So some points here may not be applicable in some cases. So that requires special understanding. Okay. So one of my friend was failed. Okay, one of my friend was failed just for doing a trans-elimination test in a thyroid carcinoma. Just it was there in the proforma, swelling proforma. Here she did a trans-elimination test in a solid swelling. Okay, so failed because she was the topper of the class. She was failed because I'm not demotivating or I'm not discouraging you, but see, application, not just the knowledge, application of knowledge is more important. See, after we become the doctor, how do we really manage the patient? See, no patient will come to you with the textbook symptoms or textbook signs or the features of pneumonia. No, patient will always present with all atypical features. So that time, how do we really manage? How do we apply our knowledge? That's what really counts. So examiners will look for that. Okay, what's your approach? How do you really approach? Okay, your findings may be right or wrong. That's not the botheration. What's the bother? How do you really examine the patient? How's your approach? How do you apply your knowledge? That will be re-examined or tested. So we will be ready for that. Okay. So what is this? One by one example for this, we'll see. What is this? See, multiple swellings, right? Multiple swellings are there. It can be multiple sebaceous cyst or multiple, neurofibroma, you're right. Or it can be anything. Okay. So like this. What is this? What is this? Anyone? Yeah, wen. Very good, Rakesh. I wanted a specific word. It's multiple sebaceous cyst or strawberry scrotum, it's called. It's also called wen, W-E-N. Perfect. Okay. So coming to the and color and all we already discussed. Okay, color we have discussed, and margins we can discuss in one of the swellings later. And extent we know how to do that. Cough impulse we have discussed. Visible pulsation, this is visible. Yeah, in palpation I'll tell about the pulsation. Movements, okay, we know. Joints also okay. Palpation, okay. Yeah, this is the real now the real examination or the doctor's job is here, palpation. So like a good doctor, let us be gentle while palpating the patient. Okay, let's not hurt them. And we will do proper order in a methodical way. We'll palpate, not simply just going and putting our hands on the swelling. Okay, we'll do it in a very methodical way. And mainly palpation is to define the anatomical boundary or anatomical origin, anatomical site of origin. To look for that, we do the palpation, and also to look for the to determine the nature of content inside the swelling, we do palpation. Okay, these are the points in palpation. First thing is uh, temperature. So examples for everything, to be ready with two examples, okay, or two reasons for each point in your case pro forma. That's all. UG examination is all about 2 points. Okay, if you know 2 points for each, you'll be definitely not just pass, you'll score really well. Okay, two important one we should remember for everything, each aspect in our clinical performer, two reasons or two causes or two examples. Okay, temperature, it can be a local rise of temperature can be there in inflammatory processes, or it can be, yeah, Rishabh, very good. Just yesterday we discussed increased vascularity in malignancies. Example is sarcoma. You know, sarcoma, there is increased vascularity. There can be, see, like this. One example like this will impress the examiner very much. Okay, so infection or inflammation and increased vascularity, or vascular or malignancy of vascular origin, you can say. Next is tenderness. Tenderness will be seen in, will be there in, where do we get the tenderness or swelling? Okay, abscess, good. Tenderness is mainly because of, it can be because of pressure, as we told. It can be the pressure exerted by the swelling or the underlying structure or the overlying skin. It can be tenderness, may be there, one thing. Second thing, due to inflammation, you are right. Third thing can be if the swelling is arising from the nerve. Okay, nerve origin, nerve related, or like neurofibroma and all. There can be, yeah, cellulitis is not yeah, even cellulitis inflammation, no, it can cause tenderness, right? Okay, these are the points in favor of tenderness or causes for tenderness. Next, yeah, we'll confirm the inspectory findings. All the inspectory findings will be confirmed now, like site. Okay, whether we are delineated the site, exactly measure the size. Initially on inspection, we just told like it was approximately 2 into 2 centimeter or so. But in palpation, we'll measure it using this verniers or scale. We'll measure it and we'll say exactly what's the size of the swelling. Or the in palpation, we can also make out the depth. Okay, in the inspection, we may appreciate the depth. So in palpation, we will, yeah, neurofibromatosis, pain present. Yeah, neurofibromatosis may be present or may not be present, but usually they present with. What is neurofibromatosis? Tell me, from where they arise? This is a common mistake we do. Neurofibromas arise from. Yeah, very good, KSK. It's not nerve cells, it's nerve sheath. Okay. Schwannoma arises from the listing nerve cells. This is nerve sheaths. Very good. Okay. Okay. So what we were discussing? Site, okay, site, size, shape. Yeah, in shape, we're telling the palpation, we can even measure the third dimension, that is depth also, and we can tell the size accordingly in the 3 dimensions. Shape also we can make out very well in palpation. Surface, now we can make out clearly what is the, you can touch and feel the for the surface. Same, like it can be soft or it can be what is that? Nodular, lobular, bosselated, whatever, irregular surface. Okay, and margin. Sometimes inspection, like in say thyroid swelling and all, we cannot make out the posterior margin and all in the inspection, but in palpation, sometimes we can distinguish the all the entire margin on the of the swelling. So we have to confirm all the inspector findings in palpation first. Extent, we will measure now with the tape and we'll tell the exact extent of the swelling. Yeah, important. Coming to the consistency of the swelling. Okay, we'll touch the swelling and feel for it. Feel the for the consistency. Okay, how does it feel like? So it can be consistency can be some 5-6 types. Okay, so first thing can be cystic in consistency. Okay, if it contains any fluid, it can be cystic in consistency. Second thing, it can be soft in consistency. Okay, soft in like in fat and all, it can be soft in consistency like lipoma and all. Then it can be firm in consistency, like in thyroid it can be, or fibroma, it can be connective tissue can be firm in consistency. Then it can be hard in consistency, hard like malignancy, it can be hard in consistency, or it can be even bony hard in consistency, like osteoma and other things. It can be bony hard in consistency. Then sixth one is variable consistency, perfect Vishrut. Okay, where there is more than one type of consistency, more than, okay, it can say variable. Give me example for each one of these. Each one of these. Each one of we told cystic is okay. You say sebaceous cyst, okay. Hydrocele, okay. Then soft lipoma, I told you, and next firm I told you already, thyroid, hard malignancy, and bony hard osteoma, and variable is again it can be hematoma, okay, acute hematoma, because chronic hematoma organized will be some form. Acute hematoma where there is a clot is formed in the periphery, but in the middle there will be still blood will be there. So there will be variable, both firm as well as soft in consistency will be there, like that 2 3 and even in the malignancy also. For saying thyroid, what is thyroid paradox? You know what is thyroid paradox in consistency? Malignant can be soft, even the benign can be hard. Benign can be hard because of calcification, whereas malignant can be soft because of the necrosis or can be because of the hemorrhage. Okay, so this is called thyroid paradox. Okay, so multiple variable swelling, variable consistency can be there. Okay, these are the example. And surface I have given you the examples, right? Smooth surface in cystic swellings, lobular in case of lipoma, fibroadenoma, any because from nodular in case of nodular MNG, matted surfaces in lymph nodes, irregular in carcinomas. Okay, it's about the consistency and surface. Yeah, now after the consistency checking, if it turns out to be cystic, okay, if it's, remember, if it turns out to be cystic in consistency, then only we do some specific tests, not in all the cases. That is fluctuation test and transillumination test. These two tests are specific for cystic swellings. Okay, how do you do fluctuation test? What is the, tell me first, what is the basis for fluctuation test? What is the principle behind fluctuation test? Of a swelling. What is the, have you heard about Pascal's law? Pascal's. What does Pascal's law say? Pressure, yeah, pressure exerted by the, okay, okay, transmission of pressure. Very good. Okay, pressure. Okay, 2 TD by Arjun. Okay, pressure exerted by the when you exert the pressure, it will be transmitted equally all around. Okay, is equally distributed in a container. Very good, Aditya. Okay, so this is also like that. When we fix the swelling first using 2 fingers, maybe your thumb finger and the index finger, with 2 fingers, fix the swelling. Okay, no, don't leave it to move. Fix the swelling, and over the swelling, just press gently. So the fluid, whatever the content there inside, will get displaced peripherally. So what happens? Your fingers will be slightly moved away. Is it clear? Can you imagine, please? Imagine just your left hand, thumb and the index finger, you are holding and fixing the swelling. Okay, and from the right index finger, you are pressing over the swelling. So whatever the contents there inside, they get laterally displaced, and your fingers will be moved away. So this is positive fluctuation test. Okay, fluctuation can be seen in all the cystic swellings, like any cysts, any abscess, hematoma, and other things. We will get this fluctuation test. And we, two things we should be careful about. What is the questions will be pseudo? What is pseudo fluctuation, and what is cross fluctuation? Yeah, slip sign is different, Sam. Okay, slip sign is in subcutaneous swellings like lipoma. Okay, when we just in the edge of the swelling, when we press, the suddenly the swelling slips away from our finger. We can't really hold the edge of the swelling. Okay, that's called slip sign. That's seen in mainly lipoma. What someone told? Yeah, in lipoma, pseudo fluctuation is seen. Correct, Rishabh. So what is so in a very big swellings which are soft swellings which are very big like lipoma, there can be in the body like they can be give a like pseudo feeling of like cystic nature. Okay, so even some say because fat remains in a fluid state in the inside the body in lipoma, so also they give this pseudo fluctuation they say. But you remember in large swellings like large lipoma or myxoma maybe, or this vascular sarcoma. Okay, this is soft in consistency, but still they can give a fluctuation. Sometimes they displace the content. That we feel like that. But how to distinguish is uh, when we see our fingers, the contents we feel like displaced, but our fingers will not move away. Clear? In pseudo fluctuation, the contents will be disappear a little bit or go move, but our fingers will not move away in case of pseudo fluctuation. Examples seen in large lipomas, myxomas, and these vascular sarcomas. Okay, in abscess there will be pain. So can we do this test? Yeah, with yeah, if it's troubling the C, always our examination everything should be patient centric. We don't learn at giving at the cost of troubling the patient. Okay, that's what my concern. I always say my juniors or my friends, we should not learn at the cost of patients like agony. Okay, so yeah, we that's why see the role of this what to say rapport building, how you manage the patient. If you build up the confidence, we talk nicely, talk with them, and build up that rapport, gain the confidence of the patient, then how much you're painful, how much it is, they'll tolerate and they'll let you do everything. Okay, they'll let you do everything. So there is a role of this good rapport building and gaining the confidence of the patient and taking to your confidence. So many times happen in exams, patients are not at all cooperative. Okay, they keep on going to the toilet. If you are asking the questions, they every 5 minutes they go to washroom and come. See, that's because we are not gaining the confidence of the patient. We just see our concern but not the patient's. We directly go to the patient, start asking our proforma, what's your name, what's your gender, what is your even gender also we ask many times just to fill up the proforma. That should not be the case. Okay, first see to their concern. They all think that you're all doctors, not the students. So just go pat on their back and say, grandma, how are you, did you had your food, how is the pain now? Simply just 2 3 questions. Okay, then your concern will be automatically fulfilled. They will only tell all the entire history in your own proforma. You need to just keep writing, that's all. Okay, so all these things important. Empathy, there's a role of empathy in our practice. Okay, philosophy aside, coming to the uh, discussion. Yeah, fluctuation test. Okay, okay, Pallavi is right. Maybe we can do it at the end of the examination. Okay, good. If the fluctuation negative, then is it necessary to do trans elimination test, sir? Okay, so yeah, if you think if it's some they may not give fluctuation positive. Okay, even the cystic, there is a role. If it's cystic or soft, we can do trans elimination test. Okay, for cystic, all the cystic swellings, we can do trans elimination test. That's the this thing. And one more, what I told is cross fluctuation. When pseudo fluctuation is over, what is cross fluctuation? If there is two separate swellings and there's a communication between, okay, intercommunication between two swellings, okay, it can give a like feel of cross fluctuation. When you press the one swelling, another may become bigger. When you press that, this like example, maybe this plunging granula, or maybe compound palmar ganglion, or then psoas abscess. Okay, psoas abscess, very good, Ajit. Psoas abscess and compound palmar ganglion, plunging granule, all this can give something called cross fluctuation. So 3 questions we should be ready. What's fluctuation, the principle, and for small swellings, we do Paget's test. Okay, what's called Paget's test, less than 2 centimeter, similar. And for big swellings, we can do entire hand. Instead of fingers, we can use entire hand for fix the swelling and for to moving. This is about fluctuation, cross fluctuation, pseudo fluctuation, and examples. Coming to the trans elimination test, what is the principle of the trans elimination test? If the content is very clear, okay, and the wall is thin. Sir, examples one more time, please. Example for, okay, fluctuation. All the cystic, most of the cystic swellings will give fluctuation positive. Then this is called pseudo fluctuation. Pseudo fluctuation seen in large lipomas, in soft swellings like large lipoma, myxoma, and any vascular sarcoma. Okay, this can give pseudo fluctuation. And third thing, cross fluctuation, compound palmar ganglion, okay, in the palm. And second thing is psoas abscess in the gluteal region. Or third thing is plunging ranula. There will be two ranula, one underneath the tongue and one more in the neck region. There will be, okay, plunging ranula. These are the examples. Transillumination principle I told you. Clear fluids transmit light. So this is a test done to look for the content. And example for brilliantly transilluminant swellings. Yeah, already Rishabh has typed. I expected question, so Rishabh typed and kept. So congenital hydrocele. Okay, two things. Okay, even a hydrocele cannot be seen all time. The content should be clear and the wall should be thin. Okay, so hydrocele and cystic hygroma, very good. Ranula, meningocele. Yeah, sometimes in thyroglossal cyst also. Okay, good. And yeah, did you tell epididymal cyst? That's also important. Epididymal cyst. Okay, epididymal cyst from the epididymis. That's about the transillumination test. Next, reducibility and compressibility. What is the difference? Both sound similar. What is the difference between reducibility? What is compressibility? Reducibility means if the swelling can be completely on pressure, on putting the pressure, if the swelling disappears completely, then it is and goes back to the, like, from where it comes from, which are cavity, okay, adjacent cavity, it goes back, and only on straining it comes back, not on releasing the pressure, only on straining. Further, it will come reappears. Then it's called reducibility. For example, just remember hernia, best example. Hernia is completely reducible. Okay, it goes back to the abdominal cavity or whichever cavity arises coming from. So only on coughing or straining it comes reappears. That is reducibility, completely reducible. Whereas compressibility is when we put the exert the pressure, only it disappears partially. Okay, the contents get displaced or some get leaked out. So it compress partially, not completely. On removing the pressure, the swelling reappears. Example is, what happened, Vishnu, today? You are one step ahead of me today. I am doing class for first time, not second time also. You are one step ahead. What I do, what I ask, everything you know beforehand, and you are answering. And I just read out. I'm reading out your answers here. That's how I'm doing the class. Great. Okay. Vascular swellings like hemangioma, okay, or lymphangioma. All these are example for compressible swellings. Okay. Good. So next, again, palpable cough impulse. If there was a just like a visible cough impulse, we can now hold over the swelling and ask the patient to cough and look for any palpable cough impulse is there. Already we discussed, no, cough impulse that was seen. Okay. Next, pulsation. Okay, pulsation means any arterial pulsation can be seen, or can be sometimes in like AV malformation and all can be, there can be trill, continuous murmur or trill will be there. So this can be, we have to look for. Pulsation can be two types. One is expansile pulsation, or next is transmitted. Okay, expansile means, see, there is a visible pulsation is there. We'll keep our two fingers over it. Over the pulsation, we keep our fingers, two fingers. Okay, so when they, along with the pulsation, if our fingers get expanded, if they are separated, then we say it's an expansile pulsation. Example, that means there is an underlying artery, or underlying artery is there. We have kept the, just below the skin there is an artery or a vessel. We have kept our fingers over, directly over the artery. So when the artery pulsates, our fingers get just separate. Just imagine, okay, there's aortic aneurysm, big aortic aneurysm is there. We have kept our fingers just above that. Okay, and when the aneurysm pulsates, our fingers get just separated. That's expansile pulsation. One more, transmitted. What happens? There is a swelling sitting over the artery. Okay, not from the artery, over the artery. Okay, so when the artery pulsates, this swelling moves up. Okay, so when we keep our fingers over the swelling, just our fingers are lifted up, not separated, but just lifted upwards. Okay, that is transmitted. So example is, just remember carotid aneurysm and carotid body tumor. Simple. Okay, carotid aneurysm gives expansile, carotid body tumor gives transmitted type of pulsation. That's clear. Okay. Yeah, Rupesh is right. Pancreatic cyst will give transmitted type of pulsation. Good. So that's about pulsation. Thrill we will see in AV malformation and all. Any AV malformation will give, there is a palpable murmur is called thrill. Okay. And fixity to skin. We do it by two ways. Uh, Either pinching the skin or just moving the skin over the swelling. Okay. This fixity to skin and fixity to underlying structure. Just it may be arising from the or fixed to the muscle or tendon or bone. Okay. We'll ask the muscle like underlying muscle to contract and relax, and we will try to move. If it's moving, fine. If it's not moving, it's fixed. Similar to the tendon. If it's not at all moving, then it means it's arising from the bone. That's about the fixity to the underlying structures and skin. This also determines the plane of the swelling. Some may ask you what is the plane of the swelling, whether it's a cutaneous, subcutaneous, deep to deep fascia from the muscle, like that. Okay. If it's above the muscle, on contracting the muscle, the swelling becomes prominent. Okay, more prominent on contracting. If it's arising from the muscle, it remains the same. If it arising below the muscle, it becomes less prominent. Okay. This in abdominal also we do the same thing. No, it's called Carnet's test, like this. So next, will lot of examples are there. So I'm moving a little faster. Okay, see, this is trans-elimination test in meningocele, in ganglion here, and in hydrocele, congenital hydrocele. Okay, all this trans-elimination test. We should have a illuminoscope made up of some opaque structure. Like better use these X-ray films. Make it like a illuminoscope and take a torch on one side, two sides of the scrotum. For example, see, not this way to be done. Okay, in exam we should do. From one side of the scrotum, we should keep the illuminoscope and watch. From the opposite side, we should put the torch light on. Okay, if the light is passed through the swelling, and if you can see through the illuminoscope, then we say, or else you can do this way in a dark room. In a dark room, you can do this way. In examination, it's not possible to have a dark room, so it's better to take a illuminoscope. Okay, coming to percussion, no role. Percussion earlier, there was no these investigations available, so they used to determine everything clinically. So there was a role. Percussion maybe again to look for the content, like in hernia and all we do. So that's the percussion. Auscultation mainly to look for any bruise. What is bruise? You know, low pitched, a short and medium pitched murmurs. Okay, heard over the this thing. Heard over each pulsation. Okay, turbulent flow. Okay, and constriction, narrowed vessel will give bruise. That will, and especially in we'll see in this thing, thyrotoxic goiter and aneurysms and all. AV malformation will give continuous murmur. Okay, we'll get continuous murmurs, machinery murmurs in case of AV malformation, and in hernia and all we can use to hear bubble sounds and other things. Okay, that's about the auscultation. Not much role you can just mention for the long case, for completion's sake you can mention, or else it's not required. Adjacent joints we should look for, very important, and movements, and deformity is there. Okay, and pressure effects, all the pressure effects should be looked for. Okay, like any, for say example, dermoid, long standing dermoid is there. It can cause bony indentation and bony erosion. Okay, so if there is a dermoid in the scalp, that can erode into the skull and cause, there will be intracranial communication can be there. So there will be typical characteristic indentation will be there. Okay, just in the edge of the dermoid there will be indentation. So we have to look for that. And neurological deficits, any paralysis is there, or any wasting of muscle is there because of narrow this thing. Okay, and vascular, I told you, any venous congestion can cause edema, or arterial we should look for the pulses, peripheral or distal pulses. If the pulses are not, if they're feeble and not well felt, then we assume that, we think that the swelling is compressing the artery. Clear? That's about pressure effects. And always regional lymph nodes should be examined if it's a mild inflammatory, or if you think it's a neoplastic in origin. Regional lymph nodes should be examined. Okay, now the interesting part of the discussion. Another 10-15 minutes. I have some 10-15 cases. We will discuss all. You will answer. Okay, I'll show the pictures. You will answer, and we will discuss in detail about the 3 particular cases, like most commonly kept, that is lipoma, sebaceous cyst, and maybe dermoid. Okay, rest of the theory part we will study by ourselves. What is that, Rupesh? Renal attribute, fungal infection can cause lymph node enlargement. Okay, fine. Okay. Oh, tell me one by one. Okay, one by one. Keep answering everyone. I want everyone to answer. Okay, I'll give you 15 seconds time for each. 15 seconds time. Be ready. What is this? Be specific. Try to be more specific. Okay, these are all spotters. Try to be more specific. Yeah, it's dermoid. Agree. How do you say it's dermoid? Okay, it's midline. Very good. It's a, so you mean to say it's not preauricular. It's in the occipital region. It's a midline. Okay, so it's a sequestration or the inclusion dermoid. There are types of 4 types of dermoid. We'll see the cases and at the end we'll discuss. Okay, so this is a dermoid, correct? We'll see some cases and at the end we'll discuss. What is this? Not keloid, not abscess also. Yeah, it looks little red, but yeah, it's again dermoid. Okay, post-auricular dermoid. Correct, Pallav. It's a post-auricular dermoid. Yeah, you can give the like whatever others told. So abscess can be, it can be. Okay, you're right. But the proper diagnosis is post-auricular dermoid. Differentials you can give others. What is this? So this, again, this is also a example for sequestration or inclusion dermoid. Various types I'm showing. What is this? Not thyroglossus cyst. It's again a dermoid. Okay, yeah. From just with the inspection, we get pickles not clear. But I'll just want to know. This is very rare. It's suprasternal dermoid. Suprasternal dermoid. Again, sequestration or inclusion dermoid. Okay, in the suprasternal region. What is this? Very classical. I'll give the history. The patient is a manual laborer who is a farmer. Okay, and he comes with this implant Shantala. Perfect. It's a implantation dermoid. Okay, see, I've given the profession. That's why important. Manual labor, they get pricks, and here and tailors, they'll have some of these pricks and all. So from that area, this dermoid will develop. When there is a prick, some epithelium will go inside. That's all. Okay. Implantation or foreign body implantation dermoid. What is this? Now tell me. Now you are all right. Since their birth, it is there in the birth and moves on. What is that? Deglutition and protrusion of tongue and all. Okay, thyroglossal cyst. Okay, it can need not be always midline. Okay, you know how the thyroglossal. What is it? What is it? It arises from what is that? It can, yeah, it can go some away from the midline also, no, near the hyoid bone. So it can need not be always midline. Okay. Foramen cecum, yeah, it's fixed to the foramen cecum. Okay. Yeah, again, what is this? Another example. Similar again. No, since birth moves with, again, this is also a thyroglossal cyst. Okay, infected thyroid cyst maybe. Yeah, correct. What is this? So there are 3 types of dermoids we saw: sequestration or inclusion dermoid first, implantation dermoid we saw. Third thing, this was also a tubulodermoid. Okay, this is also type thyroglossal cyst or what is it? Another branchial cyst. These are also types of dermoids only. So third type of dermoid we saw, and this is called tubulodermoids. Fourth, what is it? This is, what is this? This is a teratoma. Okay, sacrococcygeal teratoma. Okay, not meningocele. Okay, this is also a teratomatous dermoid. Mainly seen, not, this is not a classical example. This teratomatous dermoid seen mainly in ovary, and other things. Okay, so these are the 4 types of dermoids we saw. And see, this here is a pictures depicting how to remove the dermoid. Okay, just a small incision over the swelling, and we just remove the as intact. What to see? Write down what are the 4 points in favor of dermoid. Okay, what are salient? What are the classical features of or cardinal features of dermoid? First thing is mobile skin. Skin is free. It's because deep to skin, no. So skin is free. Okay, to roll out from the this thing, sebaceous cyst and all. Then it's a fluctuant, which rules out from the lipoma. It's fluctuant dermoid. Third thing, if in long-standing dermoids, especially scalp and all, there can be indentation, bony indentation will be there. We should always look for we should just move the dermoid away and look for the underlying bone. Bony indentation will be there, and the light, Pallavi. Fourth thing is the location. Okay, location of the swelling also. If there is along the lines of fusion, okay, some typical sites that can also give a clue of dermoid. So these 4 points are the many other things on examination, but these 4 things should be looked for. Okay. And types, 4 types we saw. Okay, that's about the dermoid. Fine. Okay, what is this? We already saw this. Again, important case, so we'll discuss in detail. Sebaceous cyst, perfect. So it's a retention cyst. It's a type of retention cyst, mainly because of the blockage of the sebaceous duct. Okay, and sebaceous duct, and this mainly accumulation of, there will be secretion within the gland. And only we should remember, punctum is okay, Tejas. But what I want to say is, only in 70 to 75% of the cases there will be punctum. If there is no punctum, also it can be still sebaceous cyst. How? Tell me. Anyone? I have told you this many times. Okay, even if there is no punctum, still there can be, it can be, yeah, Aditya, correct. Only 70% of the times the sebaceous duct directly opens into the skin. Okay, and in other things, in 20-25 times, it will be opening, the sebaceous duct open into the hair follicle, but not into the skin. In that, why there is a punctum? What is the cause for punctum? What is that actually, punctum? It's a black dot, no? What is that? This is the duct, blocked duct. Okay, opening of the duct, or it's a blocked duct with the this keratin and or the epidermal debris. Okay, it's a blocked, so that's forms the black, or mainly keratin. Okay, so this is the punctum. Okay, only in 70 to 75% it can be seen. So sebaceous cyst. So what are salient points of sebaceous cyst? Write down. One thing is punctum. Second thing is skin not pinchable. What are the other names for sebaceous cyst? Another name is there. Although when is fine, epidermoid cyst. It's called not epidermal, epidermoid. Epidermal means separate. Why epidermoid? Because it doesn't arise from the, it's actually below the skin, but still skin is not pinchable here. Okay, skin is not pinchable in case of sebaceous cyst. So it's like epidermal. So it's called epidermoid cyst. Okay, pilar cyst is a type of sebaceous cyst seen in mainly the scalp. Okay, MRI. What all names you keep, I don't understand. Okay. Sebaceous cyst, and the salient features write down. One thing is punctum. Skin is not pinchable, and it's indentable. It's a indent. What is meant by indentation? It yields on pressure because it contains pultaceous material, right? It contains pultaceous material, so it indents. Indentation present. Okay, or you can write it yields on pressure. That's the third point. And fourth is what is it? It's cystic, but still the trans elimination is negative in case of sebaceous because it's a pultaceous material, putticant material. So trans elimination is negative here. Okay, these are the 4 points in favor of sebaceous cyst. Ajit is asking in remaining 20 to 30 where no punctum, where it opens into the hair follicle or the hair follicles. So some questions about sebaceous cyst. Which organism we have discussed in one of the classes? Which organism is present here in sebaceous cyst? Fast. Demodex follicularum, correct. Aesthasiana, correct. Demodex follicularum, that's this thing. And what is it? When we know? When the multiple sebaceous in the scrotum. One more question will be asked. What is Cox specular tumor? Cox specular tumor, mainly in the scalp we see. What happens? This sebaceous cyst bursts open and this material comes out and it stays there, and chronic granuloma forms over that. Okay, chronic granuloma over the surface of the sebaceous cyst. It mimics like a fungating epithelial mass. Okay, so this is called Cox specular tumor. Sebaceous horn is different. Pavan. Okay. Next one is, what is sebaceous horn? This is also similar. The content comes out through the punctum and forms a, and it get dried up there only. Okay. The contents, whatever the come out of the sebaceous cyst, it gets dried up and layer by layer, and it forms a horn like, big horn like. So it's called such neglected cases. Okay. The patients are, I don't know, mentally challenged patient maybe. So in such patient we'll get this sebaceous horn. And yeah, someone already mentioned this sebaceous cyst can occur anywhere in the body, especially where the sebaceous glands are more, except for palms and soles. Okay, palms and soles, there are no sebaceous glands, so it cannot occur. And what do you mean by 4D's disease? These are the favorite Viva questions. 4D's, FORDYCE, 4D's disease. There are so many 4D's, 4D spots, many things. Yeah, buccal. What is buccal mucosa? These are presence of ectopic sebaceous glands in lips and oral mucosa. Okay, this is called 4D's disease. Okay, what are the complications? Sebaceous cyst complications. It can get infected. Okay, if it's get infected, we will just drain it. Okay, we'll do incision and drainage of the infected materials. Okay, but still the capsule remains there. After the infection subsides, after giving the antibiotic and all, we'll do the definitive surgery. Okay. And it can ulceration, Cox specular tumor, sebaceous horn can occur, and okay, all these are the, and what are the salient features we know. What is this again? See, it's not dermoid. There is no hair over that, so it's again, what is this? Yeah, it's again sebaceous cyst of skull. Okay, you see such neglected cases. What is this? Sebaceous, see, by the skin surface only we can make out, no, like, no, it's a sebaceous cyst, all blocked ducts. Okay, this is how we do the excision of the sebaceous cyst. We give a for other things like we saw in dermoid, we give a linear incision, whereas in the specialty of the sebaceous cyst is we give a elliptical incision, including the punctum. Punctum should be removed, or else it will recur. Okay, we should make sure that it's a small incision or elliptical incision over the punctum, and we dissect layer by layer, and the sebaceous cyst along with the capsule intact. Okay, we take out this thing. Okay, next, what is this now? Again, another important one. Lipoma. Perfect. Okay, perfect. Great. It's a lipoma. What is this? What is this? See, all the features are there. What is this? Simple benign swelling only. Don't think some soft tissue, sarcoma and other things. It's not. It's a lipoma. Okay, it's a pedunculated lipoma. It's a pedunculated lipoma, such big tumor, and there is a necrosis. See, friction due to while sitting and all, this area gets damaged and denuded. See, it's a friction ulcer. Okay, so again, there's a lipoma. What is this? Multiple lipomatosis. Very good. Dercomes. Okay, it can dercomes. So very common. Why I'm showing all this, very in our family, so many will be having. Okay, many of us will be having. Nothing to worry. Okay, every day I get calls about, see, I'm having so many swelling, sir, what to do? Please operation. No need to do anything for this lipoma and all. Okay, it's all nothing but the fat deposition. Okay, for fat, do we do anything? Okay, and this multiple, see, only for if they're causing any symptoms like near the joints, and it causing any movement restriction, or any lot of cosmetic problems are there and pain is there, only then it requires operation. Okay, only, or else how much you can remove? See, so many are there, how much you can remove? And remember, this lipoma can occur anywhere in the body, not just in the skin. It can occur in the GIT. Okay, it can be in the larynx. So this these are all very dangerous in the GIT, and it can cause obstruction and dangerous. So such things should be removed. Okay, and yeah, correct, Rupesh, you are right. In spermatic also lipoma can occur. So it's called universal tumor. Thank you so much for making us clear. And you tell me which location of the lipoma is known to undergo malignant changes. Usually it's very benign, it will not go malignant, but one place known to, not colon, liposarcoma, it's mainly retroperitoneal. Retroperitoneal lipomas known to convert into liposarcoma. Okay, they change to okay, so we should be careful about that. And what is this again? The cases we had, we obviously this patient came for a high almost exercise, almost everything. It was very apprehensive. Again, same multiple lipomatosis. Okay, so lipoma, some questions. Write down the salient features of lipomatosis. First thing is, someone told already, slip sign positive. When we touch the one edge of the lipoma, freely moves to the and slips away from the your fingers. That's called slip sign positive in case of lipoma. It's freely, skin is pinchable. Second point, skin is pinchable, freely mobile. Okay. Third thing is, it has got a very well defined borders. Unless it is intramuscular or intra-GIT, the lipomas has got very well defined borders. Okay. And lipomas and fibro, I told you, they'll have some lobulated surfaces. Okay. Very with small ones we can't make out, they look very soft, but or else usually big lipomas will have lobulated surfaces. And these usually, what's the consistency of lipoma? Usually, not always, usually they are soft. Okay. If there are other types of lipoma also, depending on the content, like there is neurolipoma, fibrolipoma, and nevolipoma and other things. So fibrolipoma can be, they'll ask you, can lipoma can be firm? They'll ask you. You should not say no, sir. You should say yes, sir. It can be firm. Yes. So when it can be formed, yes, sir. Even if it's associated with fibrous tissue like fibrolipoma, then it can be formed, sir. It can be even painful also. Lipomas are usually painless, but if it's along with the neurolipoma, along with the nervous tissue, it can be painful, sir. Or it can be a very color, like what to say, if it's associated with, it can neolipoma also. Okay, so no, Sam, it doesn't go away. Lipomas usually doesn't regress; they slowly progress. Okay, I never seen any it getting disappeared. So it slowly progress over the years and becomes slowly bigger in size. So they don't go away. Okay, this is the thing. And Derkham's disease, we know, we have to know. And see, what are the complications? It can get calcified, it can get saponified. Fat, no, it can any saponified, calcified. And I told you, retroperitoneal can go for myxomat and what is that? Sarcomatous change, and myxomatous degeneration can occur. And yeah, just know it can lipoma can occur anywhere. It can be subcutaneous, it can be intramuscular, or it can be even the bone also, periosteal. It can be even the brain also, extradural. Okay, or anywhere it can occur. And what's the treatment for lipoma? What's the treatment? All fed up, I think, all bored up. No one answering now. Excision, okay. Under local anesthesia, see all this can, under local anesthesia, we can just infiltrate the local lignocaine and we can excise if it's symptomatic or if the patient requires, patient's need, okay. So need not do. If the skin is very like what to say, very stretched out, then we can go for, to remove the redundant skin, we can go for elliptical incision or just linear incision. We take out the lipoma along with the capsule. Okay. Sometimes in diffuse lipomatosis, it need not be capsule need not be there. Okay. Only if there is a single lipomas, there will be capsule, and along with the capsule, we excise the lipoma. Okay. Yeah, you are right, Ajit. If there is no capsule, then it's called pseudo lipoma. Okay. What is this now? These are some rare ones. If the cases are available, they may be kept, but not always. Okay. Tell me. From a ganglion. Okay, it can be ganglion, correct. It can be implantation dermoid, perfect. It can be it can be fibroma. This is here it is. These are all the DDs. You're all right. Okay, I'm not telling you're all right, but here specifically for your kind info, it is fibroma. Okay, you can't say it again. It's a fibroma is a pathological issue. Not say actually fibroma, but since experience, see here if it occurs like that, it will be fibroma only by experience. We say that, but it's usually pathological diagnosis. We can't say directly. You can say all this differential diagnosis you can give like lipoma, not sebaceous cyst. No, okay, it's firm in consistency. In this where Sanya we just now told in palms and soles can sebaceous can occur. Can occur. No. So please, such things should not. Let us not do that. Okay, we'll say there is a swelling doesn't mean that we'll tell all the possible DDs of swelling. Okay, it's not like that. All the features should match. All the features should match. Very closely associated. Like see, dermoid, lipoma, very closely associated. Like one each can be one another, and sebaceous cyst without punctum and lipoma can be mimic each other. Okay, so like that it should be. This is a wart. Someone asking what is this swelling in near the finger here? See, there, notice it here. Okay, there's one near the little finger. That's a wart. Okay, wart. So whenever we say DDs, all the features of that index case or index swelling should match. Okay, can't tell all the swellings. What is this now? Her daughter also had, her son also had, everyone had. It's a neurofibromatosis. Okay, all the types and all you know, one rattling also, all those things you read, and it can be painful. Okay, it can be solitary. So many types are there. What is this now? It's not dermoid. This is a bit difficult for you, but I'll tell you. It's called plexiform neurofibroma. It's called plexiform neurofibroma. Okay, it can occur anywhere. Plexiform means this will be falling down. It will be very big away from the skin. Just go through, Google it. You will see plexiform neurofibroma. This is for PGs usually, not for. What is this characteristic again? Classical. Okay, last 3-4 slides we'll finish off. Okay, please don't. Ganglion. Okay, ganglion. See, again, it's there are 50%. Remember, very high chance of recurrence after removal. Almost 50% chances. So only if they're symptomatic, we can remove, or else we can leave it. Okay, ganglion also, nothing will happen. What is this? Ganglion. What is this? Lipoma with ulcer. Okay, this is one of the DDs, correct. It can be lipoma with ulcer, big lipoma with ulcer. And anything, see, can you make out the very prominent vessels here? And see increased, we see erythema is there, increased vascularity. Okay. Yes, sir. You're all right. It can be, it's a sarcoma. Very good, Kaushik. Kaushik, it's a soft tissue tumor or sarcoma. Okay. You're all right. Okay, I'm just telling the specific after biopsy and all done, after you are operated. No, so I'm telling the final diagnosis for you, so that when the next similar case comes to you, oh yeah, last time I had seen a similar case, so it was a sarcoma. So this can also be, you can directly like think like that. Okay, that's why I'm telling you. You're all right. It can be lipoma, whatever. Okay. Next, what is this? Multiple swellings in the neck like this, with fever. Yeah, lymphoma. Okay, sir, lymphoma. Hodgkin's lymphoma. Perfect. See here. See, this patient didn't had anything, this thing. No swelling also cannot be seen, I think. But she had all the features of carcinoma, like a thyroid carcinoma. She had all the features of thyroid carcinoma, but thyroid gland looks absolutely normal. Okay, young female, 40 to 45. Presented like this. See, on careful examination. That's why examination is important in detail. Can you see near the neck? Can you see one small swelling on the left side? See here. Can you? My pointer seen whether my pointer seen what I'm pointing? Okay. See, can it? Yeah, one lymph node is seen. No. What is this? See, just with this one, we can make a diagnosis. She has all the features of thyroid malignancy. Not virtuous, actually. It's not virtuous. It will be still lower down. Yeah, very good. Perfect, Varsha. This is what is this called? This papillary carcinoma, right? But this swelling is not a papillary carcinoma. What is this called? Not this is not for you actually. It's for PGs, but still you can. Yeah, yes, this is right. It's a lateral Sharanya, perfect. It's a lateral aberrant thyroid. They present there will be thyroid gland will not be prominent. Only they present with cervical lymph node. Correct? It's a enlarged cervical lymph node. Also called it's a misnomer. Lateral aberrant thyroid is not thyroid tissue. Okay. Ectopic thyroid is different. Okay. So this is lateral aberrant thyroid is enlarged cervical lymph node in case of a papillary carcinoma of thyroid. Perfect. Great. What is this? The simple one. Okay. It's an abscess. This is an abscess. See, I want to just show that this color changes and the margins, how irregular. See, in inflammatory, this thing, the margins will be very irregular and all, well, not so well defined and all. That's why I wanted to show you in neoplastic how the well defined margins will be there, whereas in the inflammatory, we can't really make out the margins and also. I wanted to show differentiate, so I put this. Yes, okay, abscess. Abscess, what we do for abscesses? What is that, Ajit? Features of ganglion. Ganglion, again, cystic swelling, mainly present over the tendons. Okay, you should make the tendons taut and try to move the. When the tendon is fixed, you can't move the swelling. When you tendon is released, you can slowly move the swelling, and it's mainly over the swelling. Cystic and trans illumination can be positive for ganglion. These are the features of ganglion. Okay. Yeah, this is a abscess. Yeah, what we do for abscess is incision and drainage. Okay, good. And any method of incision of drainage, any methods, specific methods, especially in cold abscess and all, we do that. Anti-gravity method. Okay, to prevent non-dependent. Very good. Okay, aspiration, cold abscess. Okay, to prevent this fistula formation. Okay, sinus formation. Okay. What is this? See, I told you, anything in surgery is a swelling, dear. Anything. Only two things it can. Yes, either swelling or ulcer. So easy, surgery. What is this? Yeah, perfect. It's not CA rectum. CA rectum will be different. It will not come out like this CA rectum. Okay. It's a rectal prolapse. Okay. It's a mucosa. See, rectal mucosa we can see. Entire rectum mucosas come out. Okay. Grade 4. Okay. It can be grade 4. You don't know unless if you're able to put it inside, you can't say Rishabh whether it's a grade 4 or grade 3. What if I'm able to manually reduce it? It can be still grade 3. So don't commit all those things. Okay. Unless you examine yourself. So this is rectal prolapse. Yeah, you are right, but yeah, this was presidential. You are right, but unless you confirm, you don't commit. Okay. See, friction ulcer was also seen over the because long standing. It was outside only. Okay, decubitus ulcer is there. Very good. What is this? Wow, what a beautiful smile. But what was she doing so far with this? I don't know. Huh? Potato nose or Hebra nose or rhinophyma, potato tumor. Okay. What is this? Okay, see, bluish. Someone told no that time there is a see bluish, sublingual this thing. What is ranula and all? Read about that. Okay. What is this? See, more classical. Again, it's a ranula. Okay. Bluish. What is this? Prithviraj into action now. Now he was so far he was not there. Now he's Prithviraj telling it's umbilical hernia means it should be umbilical hernia only, cannot be anything else. Okay. So You're right. It's see umbilicus also. Parumbilical, no, not like this. Okay. Yeah, usually we get confused between umbilical and parumbilical. You're right. See the here umbilicus also come out. Okay. So and around surrounding the umbilicus, everything is coming out. So it's umbilical hernia. Parumbilical is usually to one side of the either right or left side of the umbilicus. Okay, 2 centimeter within the umbilicus is parumbilical we say, and above that is epigastric or the other thing. Okay. So don't worry, all this okay, not mistakes, but let us be try to be more better and better. Okay, for UG level is great. If you just tell umbilical hernia, okay. What is this? Yeah. What is the clue for that? It's a keloid. What is the clue? By appearance also you can tell. Yeah, ear piercing. See, these are the sites. Okay, ear piercing. Okay, there's a common site for keloid formation. Okay, whom it's in whom it's very common is keloid. Yeah, African Americans. Great. Blacks. Okay. Dark skins. Great. What is this? A patient comes with, I'll give you the history. Don't directly tell. I'll give the history. A patient comes with anemia, asthenia, and anorexia. And this swelling. Now tell. Be specific. Pallavi. Which Pallavi? Pallavi is Pallavi T. Is this Pallavi T, our core member? Okay. What's here? What is this? Sharanya is telling. Not Kalensign. Oh, Sharani is right. It is Sister Mary. Very rare. I had got one case so far. Sister Mary, Joseph nodule. Okay, how it you know? Okay, how it through falciform ligament, all those things you know. It can be. Second thing is scar. Similar case recently I had come across one more, but not like this. It can be scar endometrioma. There's something called scar endometrioma. It can be that. And one more near the bony prominence. If it's like this, it's there. It can be called calcinosis cutis. It will be very hard. Calcinosis cutis near the bones. Okay. These are some of the DDs for that. And for this and see, don't tell umbilical hernia and other things and okay. Those are the blunders. If you tell this umbilical hernia, parumbilical hernia, then it will be blunder. Okay. What is this? Very rare. One case I got. Very rare. Very rare. I'm telling you. Not pages. See, pages is only of the nipple and areola. See, again, think. Don't simply see a breast in male. No, it's a female, I think. It's male, okay, male. Inflammatory carcinoma, but yeah, it will not like this, okay. Inflammatory will be fully wet and fully necrosed. Here, there is no necrosis as such, right? It's not Maunders also. It's not cystocircumphylloids also. Think. See, some erythema is there. Yeah, melanoma is, yeah, good. One of the DDs is melanoma. And one more is angiosarcoma. Okay, angiosarcoma. Very good, Rishabh. So, angiosarcoma. It was a big angiosarcoma, which long standing, it was gone black. Otherwise, it's a fully red. Angiosarcoma, and the second is melanoma is a very good diagnosis. Cancer and cuirassind or not. There will be skin nodules, small, not entire. This thing will be not like this. So nodules will be there all over the breast. That is cancer and cuirassind. Even in the arm, axilla, everywhere there will be studded nodes. Then it's called cancer and cuirassind. So what else? These are all not for you. Okay, don't worry. Not usual kept also for you. Just for your interest, I kept all this for you. Only 3-4 cases like lipoma, sebaceous cyst, and dermoid, and maybe ganglion will be kept. These are the 4 swellings. And sometimes even hydrocele can be short case if there are no other cases available. Hydrocele and phimosis one kept. Phimosis is a short case, and sometimes burn contracture can be there. If there are no cases available, nothing to discuss in burn contracture and all, can be kept sometimes. What is this? There's no swelling, but still I kept for you. See, let's see now your real observation. What is this? And tell me the cause also. What is this? And tell me the cause. If you tell, definitely you'll get a gift from it. It's easy, but needs your some very good. Who's that? Pawan only, I think. Huh? Yeah, Sharanya is also right. Kaushik is also right. 1 second. Okay, what is this? Okay, what's on told? Thenar atrophy is the correct answer. Yeah, due to mid-nerve palsy. Perfect. It's the answer. See, can you make out? The thenar prominence is gone. Thenar. I was telling you about the pressure effects, no, that time. So this is the example for that, for the pressure effects. Okay, due to median nerve compression or median nerve palsy. See, there is how this thenar prominence has atrophied, wasting of muscle. Okay, here. Clear? Our observation. See, small points also how important. No. What is this? Last one, I think. Classical location, classical, uh, uh, everything. This is a basal cell carcinoma, also called rodent ulcer. Why I put this? Because this is a transition for our sessions. We discuss all about the swellings, and next session will be about the ulcers. This has got both swelling as well as ulcers. So next class we'll be discussing about the ulcers. Like this only, we'll have all type of ulcers discussed. Like a case presentation only we'll do. I think Melvin is presenting a case on ulcers. He'll present, and he'll be presenting one case, but we will discuss in detail about all the ulcers. Okay, all possible ulcers we'll discuss, and how to examine all edges, margins, everything, definitions I'll tell. We will discuss. Okay, and any doubts? Sorry, it was very lengthy. I think it took a lot of time, but I think this is very important. See, almost everything, almost every case covered for you. You need not worry about the short cases now. Okay, your surgery half half practical is done. Okay. So, any doubts? Please ask any doubts or any clarifications required. Yeah, I'm very confident. If you follow this much, nothing more required to study or prepare for your short cases. Okay, 2 short cases will be there, 1 long case. Okay, even for many things in long case also we have covered, I think. Okay, hernia and many things. Please ask some doubts or any questions. We will also learn something. That's why at the end of the see. Yeah, and one more kind request to everyone. My sincere request: please stay safe. Don't go unnecessarily outside. Tell your family members also. Okay, you should motivate, fill them with confidence. Okay, please tell whatever you. Okay, you know all the what are the precautions should be taken. So follow them first, and tell others also. At least being medical students, we can if not treat, but we can create awareness among the others. Okay, difference between NF versus DERCUMS. NF is neurofibromatosis. Neurofibroma is different. DERCUMS is multiple lipomatosis. Lipoma is different. Neurofibroma is different. Multiple lipomatosis is called DERCUMS, and multiple neurofibroma is von Recklinghausen. Sir, when to comment swelling as globular, spherical, both are 3D. No. Spherical is 2D. Okay. Spherical is 2D, whereas globular is 3D. Okay. Oval is 2D, ovoid is 3D, like that. Clinical difference between congenital hernia, congenital hydrocele, newborn. Both are almost similar. Okay, not much different. So the treatment is also same, no? Okay, congenital hernia, so it will be reducible. Even in the hydrocele also, even the contents can, the fluid can go inside, unless it is encysted hydrocele. Okay, encysted hydrocele will remain. Congenital hydrocele will go inside, but the treatment for both is herniotomy only. So not much difference. It can be hernia along with hydrocele can also be there most of the times. Clinically, yeah, clinically you can differentiate by congenital hernia and hydrocele by this trans-elimination test. Hernia will not be trans-negative, whereas hydrocele will be positive. That's how we can. Okay, and consistency also. Hernia will be elastic in consistency, whereas hydrocele will be cystic in consistency. All these things. clinically you can differentiate. Okay. Any other doubts? Yeah, come. See, all this make you think. These are the questions you should be asking. Like, Shravan, are there any questions in YouTube?
As such, there are no questions in YouTube, so there's no question.
Okay, great. Okay, fine. So hope everyone enjoyed. Thank you. Glad to have you all. Enjoy studying. Any doubts, anytime, any help, let us know. Thank you so much. Have a pleasant evening. Bye.